Hey, Sam.
How are you?
If I was any better, I'd be you. Good to see you. Where's your hubby? Don't wake him up.
I'm right here.
Hi, handsome. Don't get up. How are you doing? Good to see you.
How are you?
I'm well, thank you. Hi, Jane. Barbara. Barb, down here, please. I'm well, thank you. Good to see you. Thanks for joining us. We are Penn State, I know.
Very good. But I had to get set down. No, I put it there to get out of my way. So I have to make windowsills. But no, I had to slow down between all the doctor appointments and everything going on. Martin's going to have to attack. That's Friday. Martin's getting up. Can you jam into his car?
How are you feeling?
We're down here with you guys?
How lucky did I get? This bone marrow was
Good evening, everyone.
Hi, Bob.
And welcome to this community conversation. My name is Bob Gardner. I'm the moderator here at the First Baptist Church in Haddonfield. As we begin this evening, may we bow our heads in prayer. Heavenly Father, we thank you for granting us this space that we may draw our community together, to show compassion for one another, following your commandment to love one another. Keep us safe, we pray, and open our ears and hearts tonight. Bless the participants with your presence, and fill all those present tonight with your blessing, that they may draw closer to you. In the name of your Son, Jesus, we pray. Amen.
Amen.
A little bit about our church here. We are a member of the American Baptist Churches USA, and a key to this denomination is the autonomy of each individual church. We believe Jesus to be the head of the church, and that each believer is to interpret the scripture. So unlike other Protestant denominations, particularly the Southern Baptist Convention, which is distinct from the American Baptist Churches USA, we do not have any governing authority to whom we answer. We answer to Jesus as the head of the church. This year we will be celebrating our 208th anniversary as a congregation here in Haddonfield. This congregation takes to heart the commandments given by Jesus to love God with all your heart and soul and mind and strength, and to love one another. We've partnered with American Legion Post 38 because we love the people in our community, and we wish to open our doors and invite all of you to participate in panel discussions like this, showing compassion to meet people's needs, both physically and spiritually and emotionally. If you are unchurched and are seeking to understand God's purpose for you, please come worship with us on a Sunday morning. You can meet the rest of our congregation, who is often here, some of whom are here tonight, some of whom are not here tonight. And when you meet the rest of our congregation, we hope that you will feel that loving embrace and come to understand how wonderful your life can be with Christ in your heart. Now, everybody is going through something, right? Everybody's always going through something. And as a result, as a church, we accept you as you are. As you are, with no judgment, no condemnation, we accept you just with open arms. We do have some upcoming events that may be of interest to the community. I'd like to highlight some of them for you. First of all, you may know that Lent begins on Ash Wednesday, which is coming up not far from now. Ash Wednesday will be on February 18th, and following that is our period of Lent. This church opens its doors every Wednesday at noon during the Lenten season. So for 6 consecutive Wednesdays, our doors will be open at noon for a meditation and a time of self-reflection. We offer piano music for 30 minutes from noon to 12:30. There is no sermon, there's no words. There's just an opportunity for you to take time out from your busy lives and spend time growing and re-strengthening and re-centering spiritually. Our next community conversation will be again in partnership with the American Legion, and that will be on a Wednesday evening in March. The topic will be human trafficking. And we'll be featuring a leadership of a particular ministry with the American Baptist Churches in New Jersey. That ministry is In His Image, which focuses on the issue of human trafficking. And the leaders of that ministry are here with us tonight, Judy Worgers and Lorraine Ward. So we will see you here again in a couple of months. And thank you for your interest and participation and leadership in that ministry. We also host a concert series here at the church, just to fill out our upcoming calendar for the community. The next concert will be on Sunday afternoon, March 22nd at 3 o'clock. That will be a performance with violin, cello, and piano, of interest to those who have a heart for the arts. If you wish to learn more about the church, my name is Bob Gardner. Speak to me at any time. Sramila and Moses are also members of our church. Sramila is on the panel tonight. We have other members of the church present. Jack Tarditi is here, and I'm looking around, I'm probably missing someone, and Jane is here, and Barbara is here, yes, and Betty is here. So there are many members. Please come and speak to any of us. We love to share more about our church and our congregation, our history here in Haddonfield, and we welcome all those who are seeking. Thank you. I'd now like to take this opportunity to introduce Rodney Thomas, who is the commander of American Legion Post 38, and move on with tonight's panel discussion. Rodney?
Yep. Thank you, Bob. Good evening, everyone. On behalf of the American Legion Post 38, I want to extend our heartfelt thanks for being here. Before we begin our program, I must thank the many individuals who make community conversations possible, starting with David Hunter, who's in the back there, Joe Murphy, I can't find him, he's not here, Philip Zobish, Jack and Barbara Tarditi, Lisa Quancy, who's trying to catch a bus from Philadelphia, and Dr. Moses Chandra, and of course, this beautiful Baptist church. I apologize if I missed anyone. We started community conversations to increase interaction with the people in the region. We only deal with topics that are of significant interest. We also absolutely depend on donations to continue these events. Scattered around this room, there are boxes that look like this, and there's boxes that look like this. They work the same. Okay. And no donation is too small. No donation is too big. Okay. So I encourage you to be there. Part of the money we collect will go to Breast Cancer Foundation. The event is more tonight, more than just a gathering. It's a powerful statement. It's a reminder that breast cancer has touched too many lives. It's also a testament of the incredible spirit of our community and the unwavering determination to find a cure. Each of you here represent a story of yours or another survival, a story of love, a commitment to be free of this disease. If you are a survivor, you are my very best. We're honored that Dr. Sramila, Aithal, has volunteered her time to share her expertise and compassion. When you're here today and you hear her, I hope you realize how fortunate and honored we have to have this speaker here. All right? This is a speaker who travels and speaks before thousands of people. And we are fortunate to have her. Here's the format for tonight. I'm going to make a suggestion. Put your phones on silent mode. But I've got a glimpse of what she's going to talk about. If you put your foot on silent mode so you don't see any incoming calls or text messages, but take some notes, because there's some good stuff that she's going to talk about. It's a great opportunity to do that. Jack Tarditi will make a few opening statements and introduce Dr. Aithal. after Dr. Aithal speaks, we'll allow the audience to ask questions. We have 3 individuals here who are part of a panel. They're survivors. And they will share their survivorship experience. And Dr. Aithal will make some comments about what they've said, and then you, as part of the audience, can ask some questions. We also have something that was gifted that I was not expecting. But if you are a survivor, you can take a rose with you.
Any woman.
Any woman. Oh my gosh, I stand corrected. Any woman, and oh, by the way, if you're a guy and you've had breast cancer, you have my permission to take one of these, okay? They were donated by two ladies, Leslie and Nicole. All right, Jack, you're on stage, and I know you're got a close friend in Dr. Aithal, and go for it.
Thank you, Rodney, and let me, on behalf of the First Baptist Church, add my greeting as Bob Gardner gave. We're honored to be able to do this. I think that this is an important part of our community, service to the community. We're fortunate in that this young lady here and her husband are very dear friends of ours. They're both physicians. Moses got hit today by a truck. But Sramila is an expert in this field. He's renowned. In fact, a little bit about her, as I'm going to read because I don't want to mess up my introduction, so I'll be getting a hard time from Rodney. She is an advocate for innovative, personalized care and the development of advancements in breast cancer treatment and women's health. She's very involved in high-risk breast cancer protocols, clinical research, and national benchmarking initiatives. In fact, I know she spoke this past year, I think Pittsburgh. She speaks frequently around the country about breast cancer. Before joining Alliance Cancer Specialists in Ben Salem, Dr. Aithal specialized in breast cancer and gynecological malignancies at Cancer Treatment Centers of America in Philadelphia for more than 13 years. In addition to her extensive training, I gotta call her Sramila. Sramila previously served as a chief resident in Malamides Medical Center in Brooklyn, overseeing one of the largest internal medicine residencies in New York. She's been chosen by her peers as one of Philadelphia Magazine's top doctors, a distinction awarded to Philadelphia region's best physician. She was named one of the Castle Connolly's top doctors, as well as the 2020 Exceptional Women in Medicine. She's been featured in magazines, television, newspapers, and educational sites. She certainly went to medical school in India. In fact, that's where these two met each other. That was a blessing for Moses, meaning her. But she's exceptional, and we're proud of having her as our one of our members. In fact, she serves as chair of our board of our diaconate, and she is a blessing to this community. Let me introduce Dr. Aithal. Thank you for coming.
Thank you. Thank you, Mr. Tarditi, for that introduction. It wasn't necessary. I'm humbled to be here. First off, I do want to say thank you sincerely to each and every one of you veterans that are here, families, caregivers, for your service, for your commitment, for all that you do, not only to our country, but to the community and to each other. We're honored for your presence at our church, and I say thank you once again.
Thank you.
I'm so delighted to be here. It's an honor for me to be here amidst you, and particularly at my church. This is my church. Here's where we come to worship every Sunday. Well, today we're going to talk a little bit about breast cancer. As you know, it is such a vast topic. Obviously, I will not be able to cover everything and anything, but what I thought was going to be more practical, feasible, I did put in a few slides, which I'm going to share. And if time permits, may also touch briefly upon prostate cancer, if time permits. But mostly I want to open the floor for discussion and be more engaging. It may be slightly different as compared to other conversations with the community that you guys have had, but we'll see how this goes. I do have the honor of one of our breast cancer survivor here with me, Miss Sharon, who has volunteered to share her story, her journey of breast cancer briefly, so that it puts everything into perspective. I also want to say, please stop us at any time to have any questions, comments, or anything that you might want to share. May I just invite Ms. Sharon to please share her brief journey with us?
Thank you. Number 2, since Sharon had said number 2. Thank you. Hello, everyone. I'm so honored to be here. I was talking to Ms. Laura and Pastor David and the congregation in this beautiful church in the American Legion. I just want to thank you so much for allowing me to be here, because I'm just so honored. And Dr. Aithal, thank you so much for asking me. And I guess by now you already realize that Dr. Aithal is my doctor. Yeah! And I praise God for that. Because, you know, first of all, I'm going to just say this real quick. I'm a real scary person. Yeah, absolutely. I'm not a superhero. I was scared. Scared absolutely to death. But I thank God that, you know, God knew exactly what I needed. He knew that I needed someone that was patient. He knew that I needed somebody that was kind. And he knew that I had so much anxiety. So you know what? He directed me to the right doctor. And I believe that was just a plan that God did for me in my life. Because you know what? I would come to her and I would say, look at this. Dr. Aithal, what is this? And she would say, Sharon, let me look at it. Let's see. And that's what God is like. He's Christ-like. He doesn't pull us away. He doesn't go, oh, you're crazy. What are you doing? Are you driving me crazy? Let's see, Sharon. Sharon, you're all right. And I thank God for that. And I praise God for that, because I know that God directed me to this doctor. Hallelujah. Thank you, Jesus. God is amazing. In my walk, in my journey that I went through, he has been there with me the whole time. Because as I said before, I'm no superhero. And you know, there's a roll call. Susan, John, Karen, Kevin, David. You just never know. Because you know, cancer goes across the board. To young people, older people, all races. It doesn't matter. It goes across the roll. And guess what? In March 2018, there was a roll call. And the roll call said, Sharon Fitzgerald, breast cancer. And guess what? I didn't want to sit here. My hand was like, no, not me. No, not me. You know, God had blessed me where I had just adopted 2 beautiful little girls. Oh, not me. I always wanted girls. I always wanted children. Here I am, this person that just had a newborn and a 4-year-old. I was praising God. Look at God, I think I adopted. And all of a sudden, it's like, not me. And of course, at that time, they were older, but still, not me. But you know what? I thank God, because as my journey has gone on and on and on, God has truly blessed me. I'm doing well. I'm cancer-free. Hallelujah. Thank you, Jesus. I'm cancer-free. That's a blessing. And I have a good doctor that talks to me, asks me, are you taking your medicine? Are you doing what you're supposed to do, Sharon? Sharon, are you listening? And I thank God because that's the blessing God gave me. And once again, I just want to say thank you. I am so honored to be before you because it's a blessing. Because I don't have to be here. I don't have to be here. But because of the mercy of God, and because he felt it was worthy, he felt that I was worthy enough to be alive, worthy enough to have a doctor, someone that cared about me, someone that understood my personality, and blessed me to be here. So I stand before you happy. I stand before you carefree and cancer-free. I stand before you blessed because those two little girls are now 14, of course, because they were older at that time, but they're 14 years old, and one is in college, 4.0 grade average. And I thank God because I thought that I'll probably never get to see everything, but God is amazing. And I thank you.
Sharon. I appreciate
God
it.
bless you. Yeah. So thank you, Sharon, for sharing your story. By the way, Sharon has adopted 2 Syrian girls at that time when you know there was crisis in Syria with all the refugees. So thank you for doing that as well. I'm going to briefly go through some of the information about breast cancer. And as I put up these slides up there, it may be difficult for you guys to see. It's too bright here, but I'll just share some words. So the incidence of breast cancer, as you know, you see it's #1 on the list here amongst women. More than 300,000 women each year get diagnosed with breast cancer. And when you look at men, it is prostate cancer. That's #1 diagnosis.
Sramila, 1 second. Moses has taken the lights down so that people can...
Yeah, that's fine. I'll go ahead as you keep doing it. And at the same time, when you look at mortality from cancers, breast cancer is second to lung cancer. Likewise, prostate cancer, this is number of new cases, and this is number of deaths from cancers. About 14% of women succumb to breast cancer. We cannot accept this in this day and age. They have to do something different. No doubt, lung cancer happens to be the leading cause of mortality in the United States, both in men and women. Well, we have to do something about that as well, but we certainly have come a long way when it comes to lung cancer with many, many newer therapies, newer forms of treatments that have become available that will people live longer with lung cancer. But then with so much of research that's happening, newer technologies, newer developments, we still need to do a lot more in terms of saving up women from succumbing to their disease. So what can we do? Obviously, prevention is the key, but also early diagnosis is the key as well. Screening is available, fortunately, for breast cancer. We don't have screening for all cancers, unfortunately, because we have to come up with a test that is feasible, economical, and also more sensitive and specific for a given cancer. But for breast cancer, we do have screening, and that's with mammogram. And when do we do all this? Women at age 30 should be assessed what their risk is. Are they at an average risk for getting breast cancer, or are they at a high risk? How do we do that? It would be best to have a discussion with your primary care or OBGYN, obstetrician, finding out about what your personal history is, what's your family history, and what are some of the symptoms, and so on. Beginning age 40, every woman should be getting a screening mammogram. The kind of mammogram that's done these days almost everywhere across the United States is either a 2D or 3D digital mammogram, which is more sensitive in picking up abnormal findings. Earlier, we used to have a cutoff for stopping with screening mammograms, which was around 74 years or so. And that has changed. There is no cutoff date for stopping screening mammograms. You would continue with screening mammograms as long as your health is doing well. And if you have at least close to 10 years mortality, you would continue with screening mammograms. And of course, there's differences when your risk differs. We'll talk about that in a bit. Now, unfortunately, We have so many agencies across the states that gives us different guidelines and confuses quite a bit as to when screening should happen. There's the American College of Radiology, there's United States Preventative Services Task Force. Each of them have come up with their own recommendations. And there's, of course, American Cancer Society. But in general, what we need to know is women should start screening with mammogram at age 40. It's preferable to do once a year because some of the agencies have guidelines to do once in 2 years, and keep it going for as long as you remain healthy. And there is no cutoff date for stopping with screening mammograms. It is perfectly okay if you want to switch to once every 2 years if you are at an average risk. Now, ultrasound, some people say, oh, I don't want to get exposed to radiation, why can't I do an ultrasound? It isn't a sufficient test for screening. It is used as an adjunct if there was something abnormal seen on a mammogram, and it can help distinguish between a benign tumor and cancerous tumor. It can help distinguish if you have thick or dense breast tissue, but it's not a tool used for screening purposes at all. Now, it's not just enough to just do mammogram and be done with it. You need to know what to do with that mammogram, right? So if you do a screening mammogram and you get perfect results saying nothing's wrong with the mammogram, you're good to go, then yes, you're good to go and you would repeat your mammogram again in another year. But say they saw something on mammogram but they aren't clear what that is, then you need an additional imaging study. That additional imaging study can be either an ultrasound or what we call a diagnostic mammogram, meaning it's another mammogram where the cuts are very thin that can pick up anything that's abnormal, and sometimes even an MRI of the breast. And if that additional imaging study says that there isn't anything of concern, you would go back to doing your annual screening mammogram. But if there was something of concern and it warrants a biopsy, well, the next step is to proceed with a biopsy. If the biopsy comes back as there's nothing of concern, it's benign, then you would go back to doing a little bit more frequent screening. Maybe in 6 months, you need an additional diagnostic mammogram to ensure that it wasn't missed. But on the other hand, if it turns out that it is cancer, then you would proceed with the treatment for it. We need to know what's the risk of breast cancer in every single woman and few men. So the average risk is about 12.8% or so during one's lifetime. In other words, 1 out of 8 women will get cancer in their lifetime. Not at a certain age, but throughout your lifetime. This is an average risk. But if you have a slightly increased risk, like a moderate risk, you have about 15 to 20% chance of getting cancer, breast cancer, in your lifetime. But if you have a high risk, it's more than 20% risk of getting breast cancer during your lifetime. So we need to know this, and how do we do this? How do we know this? Okay. Before I tell you how do we know this, we need to know what are some of the risk factors. There are minor risk factors which increases your risk of getting breast cancer by a small amount. Relative risk anywhere between 1.2 or 2 times more, or 1.2 to 1.5 times more than average risk. And of course, there are some risks that can be modified, but there are also some risk factors that you cannot modify. So it is shown that drinking alcohol, 2 glasses of wine every day, increases risk of getting breast cancer. Or having weight, being in the obese range, increases risk of getting breast cancer, particularly if you've attained menopause. And of course, lack of physical activity or smoking or bad diet, all are risk factors for getting breast cancer. But they're not some modifiable factors. You cannot control when you get your periods for the first time or when you go into menopause. So the extreme ages often happen to be a risk, or not having any children happen to be a risk. And of course, menopausal hormone replacement therapy, there was false notion spread for the past 2 to 3 decades that it increases the risk of getting breast cancer. But of course, that study was proven wrong later on. It's not universal for all women that taking hormone replacement therapy with estrogen hormone when you get into menopause will increase your risk of breast cancer. That's not true. It may be applicable to higher risk women, but not for all women. But nevertheless, there's other high risk features that you need to also look into. And these may not be modifiable. You can't control if you have a family history of breast cancer, which certainly increases your risk of getting breast cancer by close to 20% or 20 times more, relative risk of 20 times more than the average woman. Or if you have hereditary genes that you're born with, passed on from your ancestors, you have a high risk of getting breast cancer along with other cancers. You can't do anything about it. And sometimes you can have some lesions within the breast which are not considered cancer, but a marker for cancer to happen in the future. They increase your risk of getting breast cancer by about 5-6 times more. And dense breast tissue, it's not all dense breast tissue increases risk of breast cancer, but if it's uniformly dense, then it may increase a little bit. So how do we know what each of our risk is? There are many online tools or websites that's available where you plug in your features, your age, your menopause status, how many children you had, what's your family history, and it comes up with a score, and that score tells you what is your risk of getting breast cancer. Although there are so many tools that's available, not every one of them is reliable. You need to be aware of that. So I presented 3 here. For instance, the first one, Gale model. It used to be frequently used, but there's so many flaws with it. It's only looking at white women. We don't have variation in ethnicity in this tool, so it may be different for other groups of women. Most commonly used tool or website is the last one, TryoQSIC. That kind of incorporates as many features as possible. I put in the web pages there, but you can look into it if you want to, or your doctor can guide you in terms of finding what your risk is. Are you at an average risk, moderate risk, or high risk? Prevention is the key, as I said earlier. What can you do that's in your control? Not everything is in our control. Some of the genetic makeup is beyond our control. Not necessarily hereditary genetic makeup, but the spontaneous genetic mutation is beyond our control. But what is in our control? Definitely paying a whole lot of attention to diet, exercises, see what you're putting into your body, make sure you're moving around, and ensure you're limiting your alcohol. These have some level of evidence to say it can certainly reduce your risk. But we also see occasionally, or maybe frequently, women who come to me in the clinic and say, I have done everything possible. I exercise, I eat healthy, I do not drink alcohol nor smoke, but why did I get breast cancer? Yes, this spontaneous mutation, there's nothing you could do about. Unfortunately, that happens. I put in a few myths because many times women ask me, should I be doing this or not? But these are still considered myths. They're not real. You know, people ask, should I not be eating any sugar? Yes, you cannot indulge in eating sugar every single day, eating a cake or whatnot, but it's not proven that it'll increase your breast cancer. Or people don't get mammograms saying that too much of exposure to radiation will itself cause me breast cancer. That isn't true. The amount of radiation you get with the mammogram is so minuscule that it does not increase risk of getting cancer of any kind, let alone underwire bras for women. So these are all myths and it's not real. So stay tuned until we get more information, but it is not a risk for cancer at this time. Yeah, so I wanted to have a word on how do you stratify some of the risk factors. So majority of the time, women get breast cancer because of spontaneous mutation that happens within the genes in our body that leads to cancerous cells and in turn becomes cancer. But then in about 10% of women, they get breast cancer because they are born with this hereditary gene. The commonest genes is referred to as BRCA or BRCA genes, BRCA1 and 2. That only happens in 10% of women who get breast cancer. You can have this hereditary gene coming from either your paternal side, your father's side of the family, or mother's side of the family. It doesn't always have to be coming from the mother's side of the family. If your mother carries the gene, there's a 50% chance that you are having that gene. This hereditary gene causing breast cancer accounts for only 10% Most of the time, it's spontaneous mutation. And another 20% or so, it's the familial risk. You can have family members with breast cancer that increase your risk, but it doesn't necessarily mean it's hereditary risk. It's a familial risk. That's something you need to be aware. In the event one has a hereditary gene, BRCA1 and 2, see how high the risk of them getting breast cancer in their lifetime is. 80%, up to 80% chance of getting breast cancer if we carry BRCA gene. It's not just breast cancer that happens when you have BRCA genes. You now have a risk of getting prostate cancer in men. About 20-25% of men, if they have BRCA gene, can get prostate cancer. You can get pancreatic cancer in both men and women, one of the deadliest form of cancers. And of course, ovarian cancer, and a few other cancers that it can cause as well. So we need to know, importantly, what is our risk. This is a structure of a breast tissue that I just put in to show the anatomy. As you see in the picture to the right, it's made up of fat tissue, the yellow color that you see primarily. And then you have those grape-like structures that we call them lobules. That's where the milk is made. And then the milk flows through the ducts, which comes out through the nipple. When cancer happens in the breast, 90% of the time it happens within the ducts in the breast. We call that cancer invasive ductal cancer. Now, in the carton to your left, you see a picture with the green lines and little dots there. That's our lymphatic drainage, our lymphatic channels. Our entire body is filled with lymphatic system that drains lymphatic juices. It is pretty common for breast cancer when it happens in the breast to spread to the lymphatic channel and enter the lymph nodes. All the lymph nodes are connected with one another, and that's how there is a chance for breast cancer to travel and spread anywhere it wants to throughout the body. Now, we have to pay attention to the symptom that we may have. If anybody is noticing a mass in their breast, changes in their nipple, redness in the breast, pain that's unusual, please bring it to the attention. And we want to know about staging of breast cancer briefly, because treatment differs based on the stage and prognosis differs based on the stage. There are 5 stages in breast cancer, stage 0 to stage 4. We would say it's a stage 0 when it's just superficially present in the duct or the lobule. Subsequently, based on the size of the cancer or tumor within the breast, has it spread to the lymph nodes? If so, how many? And has it gone elsewhere outside of the body? It can travel through the lymph channels, through the blood vessels, and it can travel to the bones, to the organs like our lungs, liver. It can travel to various other lymph nodes. It can travel to the brain, and that's considered as stage 4 cancer. So, like I said, it's important to know what is a stage of breast cancer. The next step is it's also important to know what is the type of breast cancer one has. Now, breast cancer expresses what we call estrogen hormone, progesterone hormone. These are female hormones that we make in our body. So 70% of breast cancers do express these hormones, estrogen and progesterone. When they are overly present, those hormones they're receptors in the breast where the hormone sits in them, and they're sending signals to allow breast cancer to grow. So we call that cancer estrogen hormone positive, progesterone hormone positive. And then we also have what is called a protein, HER2/neu. That is overly expressed in about 10 to 15% of breast cancers. We call it HER2 positive type of breast cancer. And then in about 15% of women, all these 3 different proteins are not present. We call that cancer triple negative cancer. Triple negative cancer happens mostly in African American women, and it tends to behave in an aggressive manner in African American women. We're still figuring out why that is the case. But like I said, hormone receptor positive and not having HER2 protein is the most common cancer. It's the favorable type of cancer. Nevertheless, 20% of these women do have recurrences. Now, an overview I'm giving for breast cancer treatment. When somebody gets diagnosed with breast cancer and it is in its early stage, the first thing we look at is, can we operate and take out cancer? It makes sense, right? So surgery is the mainstay of breast cancer treatment. They can only do 2 types of surgery on the breast. either take out the whole breast, which is called mastectomy, or take out part of the breast, which is called lumpectomy. We don't always have to remove the entire breast, just a portion can be removed. And at the same time, they examine 1 or 2 lymph nodes for any presence of cancer cells in there. When we take out the whole breast for various reasons, either the tumor is very large or they have a high risk factor for getting cancer another time, like carrying those BRCA genes, or the tumor is in multiple places. Unfortunately, sometimes we may have to do a mastectomy, or it's someone's choice. A patient may have a choice. If we did remove the whole breast, there are different ways we can do so. We can leave the skin behind, we can leave the nipple behind, we can take out everything as well. And after they get their surgery, sometimes we may have to do what is called radiation. Radiation is not necessary all the time, but if someone has just had a portion of the breast removed, they will need radiation to that area, and that is to prevent any further cancer cells from remaining alive and causing it to reoccur or spread to other places. This is removing a couple of lymph nodes. We don't take out all of the lymph nodes like we used to several decades ago, but that leads to a side effect, what we call lymphedema, so we don't do that anymore. And if you do have the whole breast removed, there are different ways we can reconstruct the breast tissue. You can put in an expander and later replace with an implant. You can take out fat tissue from the belly or the back and put in a flap there. So these are different ways of reconstruction, as I mentioned about radiation. And the next thing is chemotherapy. Not everybody wants or needs chemotherapy. I have some issue moving my slides. I'm not sure if there's a trick in keeping it closer. Okay. Not everybody warrants or needs chemotherapy. It is necessary in some subtypes of breast cancer, or if the cancer is picked up at a much advanced stage or later stage. That's when chemotherapy is warranted. As a matter of fact, of late, we have tools that's available where we can figure out, can we omit chemotherapy? Can we de-escalate their treatment? Can we avoid giving them some toxic drugs that gives them a lot of side effects? But in certain types of breast cancer and in certain stages of breast cancer, it becomes necessary. The intention of chemotherapy is to prevent those cancer cells from traveling to other parts in our body and thereby prevent a spread of cancer happening. That's the purpose of chemotherapy. Now, as I mentioned earlier, some cancers, majority of breast cancers, express estrogen hormone. When you know estrogen hormone is feeding your breast cancer, you can counteract that by giving an anti-estrogen hormonal therapy. So that may become necessary, which also prevents cancer from spreading to other parts in our body. So that being said, with all of these treatments, we sometimes still see cancer reoccur and spread to other places. That's when we call it metastatic breast cancer. Whether it may have spread to just one part, say a bone, or it may have spread to bones, lungs, liver, it is still called metastatic breast cancer. If that's the case, we have a lot of treatment options available to put those cancers in remission, but we don't say that we can cure those cancers. But there are plenty of treatment options available, and women do well. There are women living with metastatic breast cancer for decades. It doesn't apply to all. It depends on their cancer's features, but it is encouraging to know that there are women living with cancer for a long time. The key thing right now is, how do we monitor after one has finished with their diagnosis of breast cancer, and how to help them with all of the treatment-related side effects that may happen. That's really the important one. Why? Because we want to give women back their quality of life as best possible. For a brief period of time, they were disrupted from whatever they were doing, whether it's attending to their work, attending to their homely duties or whatnot, but we want to give them their quality of life. Some of the treatments leave us with some side effects that we need to watch out for. Whether it's bone density loss that happens with a condition called osteoporosis. You don't feel it, you don't have pain, you don't have symptoms, but your bones become brittle and it can break easily. Whether some of the medications that one received can lead to cardiac toxicity or heart damage, it needs to be monitored as well. Whether surgery leads to a condition called lymphedema, it needs to be looked into. Many a times women ask, why don't I get PET scan, CAT scan to make sure that my cancer has not come back? It isn't routinely necessary. We go based on symptoms because there's no advantage by doing scans proactively and picking up cancer as compared to doing scans at the onset of symptoms. There's no survival advantage that is seen. I highlighted some of the side effects that happens and how we manage them. Most common side effect that occurs to women is menopausal symptoms. We refer to it as what we call vasomotor symptoms. They have things like hot flashes, night sweats, skin dryness, vaginal dryness, mood swings. These are extremely common, maybe because of the medication that's blocking their estrogen and they don't have any estrogen anymore. Or it is also because they are already in menopausal state at the time and the hormones just are again deprived and the symptoms just worsen. They also present with a lot of sexual dysfunction as well. So how do we address that? It makes sense when they have symptoms related to lack of estrogen to give them an estrogen hormone to overcome those symptoms. But it doesn't make sense for their breast cancer. The breast cancer grows because of estrogen hormone. So you can't give them estrogen hormone, unfortunately. So, like I said earlier, this hormone replacement treatment in menopause can be given, but not to women who have breast cancer. Especially oral estrogen hormone cannot be given to women who have breast cancer because that's going to make their cancer grow. We have 2 new drugs that got approved in the past year, one of which you may probably have seen advertisement on television. It's called Veoza. It's a non-hormonal medication primarily meant to help reduce hot flashes and all those menopausal symptoms that works wonders. But as you know, when you come up with a drug, that drug has its own side effects that you have to deal with. So it's pick your poisons. What is worse? You try to address that. But there are other medications to help hot flashes, particularly that we use for treatment of depression. A few medications work well in treating those hot flashes or other menopausal symptoms. But keep in mind there's some non-pharmacological measures, non-medication measures to help treat these symptoms. Acupuncture has proven to help with a lot of symptoms, whether it is hot flashes, mood swings, or other symptoms like lack of sleep or neuropathy or nausea, vomiting, whatnot. And there's something called cognitive therapy that is shown to help with the symptoms as well. But we need to inform your doctor about the symptoms that you have and allow them to explain what they can do about it. Moving, physical activity is the key to help with many of these symptoms. We also have to make sure we look into other aspects that we're not missing out. It may not just be related to their cancer treatment, but it could be some other things that's happening at the same time as well. Should probably go here too. Yeah. So lymphedema, as I mentioned, this is one of the side effects where the arm swells up because if they take out lymph nodes from the armpit area, there is obstruction to the flow of lymphatic juice, and so that results in stagnation, and so the arms swell up, it causes discomfort and pain. There is treatment available for lymphedema. It's not just putting on a sleeve, as you may have seen some women do so. There's excellent therapy. In fact, we do have the director of physical therapy here. They do massages. There is lymphedema pump that they can do. There is lots of other things that can help manage lymphedema. But we need to address that and make time for taking care of these symptoms. And as I mentioned, bone density loss earlier. Unfortunately, with bone density loss, many women don't pay attention to it because you don't feel it. You don't have symptoms. If you have pain in your bones, it's not from osteoporosis, it's from arthritis. But bone density loss or osteoporosis can break your bones because your bones are so brittle. It can lead to fracture in your hip or your spine. Those are the 2 common areas that osteoporosis hits you. So vitamin D is one of the key medication to take. Moving, exercises, walking, climbing stairs, lifting weights, those are the things that helps. And if you do have osteoporosis, there are treatments available to help with that as well. This is another thing that women do experience. They don't feel like they are themselves when they've gone through treatment for breast cancer. There is so much of what we call fogginess. They don't feel clear. They don't feel sharp. They don't feel like they're able to solve problems or remember things, where they put their keys or bank account or things like that. That can happen with treatment for breast cancer. So we can certainly improve this cognitive dysfunction by therapy that's available, which once again, cognitive physical therapy that can be available through physical therapy that you could do. But at the same time, sometimes you may be lacking, say, vitamin B12. You can be deficient with that, and that can also contribute. So you may need to check on those as well. And there's help available for that. And then sexual dysfunction. Unfortunately, this doesn't get talked about because, first off, women feel hesitant to bring it up at their appointment with their oncologist. And also the oncologist is so busy doing a lot of things that they fail to address this. There is certainly concerns with the treatment with sexual function after treatment for breast cancer, whether it is low sex drive, whether it is vaginal dryness or pain and things like that. But, you know, a simple thing like pelvic therapy can help with it. There's also other options that we can help our patients as best possible, but we need to discuss this. We need to make time to overcome this. Lack of sleep, that's another commonest thing that women complain about when they have received treatment. Even if they've gotten estrogen blocking drug, it doesn't allow them to sleep. They are wide awake in the nighttime. But again, it's not just throwing in a pill, sleeping pill to help them with it, but it's important to address their sleep hygiene. Make sure they're not drinking plenty of fluids in the nighttime. Make sure they're not on their screen time, like having their iPad, phone, TV. Make sure that they're not having caffeinated drinks in the evening or whatnot. And of course, if it's really bad, there is medication that we can resort to. This is really, really important. Being, connected with one another in the community, talking about it is the key. I mean, it is really helpful to do so. You don't have to share everything of yours, but it helps you to be social. When I becomes weak, illness becomes wellness. I just want to say a word about male breast cancer. It's a common knowledge that everybody thinks it's only women that get breast cancer. It's not the case. Men also can get breast cancer. 1% of all breast cancers happens in men. So 300,000 women each year get breast cancer, of which 1%, meaning 3,000 men, can get breast cancer. And if a male person has those hereditary genes, the BRCA genes, they have even higher risk of getting breast cancer. We don't necessarily have to do mammograms for men. Why? Because it's, number one, only 3,000 men each year get breast cancer. Secondly, the fatty tissue in the breast for men is very little. If they do have a mass, it is easily felt. So they come with symptoms. They feel a lump, they feel a mass, they feel something's not right. That's when you do workup. And they are treated exactly the same way as you would treat a woman with breast cancer. The same way with surgery, radiation, estrogen blocking drug, chemotherapy if it's warranted. So it's really important, if any men feel something that's not right in their breast, they should bring it up and not hesitate, because sometimes it can be presented as much advanced disease. All in all, when someone gets diagnosed with breast cancer, we resort to various ways to help us cope with it. It may be through your family and friends. It may be through your hobbies. It may be talking to many support groups. But spiritual guidance for those that have faith, whatever you believe in, is extremely important. Even in the Bible, there is many places that it states God will help you restore your health. I just put a few of them for references, but again, thank you. I just put a few, but it's important to be aware that where you want to lean to, there is help that's available. Maybe I can briefly go over prostate cancer and then take questions, and is that okay? We have a little bit of time. I have very few slides on prostate cancer. So I wanted to say briefly about prostate cancer. As I showed the first slide, you saw that the incidence of prostate cancer, again, little over 300,000 men each year get diagnosed with prostate cancer, and it's the #1 cancer that happens in men in this country. And it's also the second most common cause of death from cancer in men in this country. So that's really important to note. So let's see, what can you do to prevent cancer? So first off, a word about prostate. Where is it? What does it do? Why is it important? It's a walnut-sized shaped organ that sits below the bladder. I wish I could have shown you. So that sits below the bladder. The red thing on top is a bladder. And the walnut shape, which is separated by different lobes. And then it is in front of the rectum, and it is very small in size. It has 3 different lobes, the right lobe, left lobe, and a posterior that's underneath the bladder. Now, it helps make semen, and why cancer happens in the prostate, we don't really know. Once again, it's spontaneous mutation that occurs in our genes that causes prostate cancer. And sometimes it could be inherited, as I mentioned, BRCA gene. If one has 25% risk of getting prostate cancer. But sometimes you can also get BRCA gene not through your ancestors, but you can acquire BRCA gene in your lifetime in men for prostate cancer. That can increase the risk of prostate cancer as well. So that is something to be aware of that can certainly cause prostate cancer. Now, of late, the incidence of prostate cancer and advanced stage of prostate cancer has increased in the past few years. If you may ask why that is, there was a huge controversy about screening for prostate cancer, and especially an agency called United States Preventative Service Task Force that comes up with the guidelines a few years ago said that men don't need to be screened for prostate cancer, and because of that, screening was not happening, and men now are diagnosed with much advanced stage of prostate cancer. Of course, the guidelines now have changed, and there is parameters as to when they should start with screening. So it happens in much advanced age, prostate cancer, but we're also seeing younger men in their 50s get diagnosed with prostate cancer. It also happens to be more common among African American men, and even African men, particularly from Caribbean area. And if they get diagnosed, it happens to be much more aggressive, which we are not quite sure why that is. Diet certainly plays a huge role. Having fatty diet, processed meat, more of eating bacon, red meat, and things like that, lack of vegetables, fiber, and fruits in the diet increases risk for getting prostate cancer. And of course, it differs based on where you're located as well. Family history is very, very important. As I mentioned, if you have family members with prostate cancer, your risk is probably doubled up of getting prostate cancer, and you need to know what's the hereditary risk. Now, not all prostate cancers presents with symptoms. Early stage prostate cancer has absolutely no symptoms. If there are symptoms, the symptoms may be either its urinary symptoms, urgency, increased frequency, in the nighttime want to go more often. If you have those symptoms, it doesn't always mean that one has prostate cancer. You need to look out for other things as well, but these are some of the symptoms to watch out for. If there is any blood that you see in the urine, that's often a concern as well. And then sexual dysfunction, that's a concern as well. But as I said, many men are getting diagnosed with more aggressive form of disease. So symptoms happens when the cancer has spread to bones or other organs. They present with pain or based on where the cancer has spread to, sometimes even loss of bladder or bowel control. How can you lower your risk of getting prostate cancer? Everything boils down to only a couple of things. Make sure you're physically active. Make sure you have exercises. Make sure you're maintaining your body weight that's appropriate for your height. You're not obese. And make sure that you're not smoking or drinking alcohol. So increased intense physical activity certainly helps protect you from getting prostate cancer. What should you not be doing? As I listed a few of those in there, avoid processed food, excessive sugar, and alcohol. But of course, if you have a diet that is filled with balanced diet, with lots of fruits, vegetables, and yes, you can have meat, poultry, and things like that, or fish, but not processed food like bacon and things like that. You're definitely going to protect yourself. So how do we start screening, and when should we be starting screening? So screening can be different for different age groups. And screening is done with a blood test called PSA. If you have an average risk, no family history, nobody in the family has any hereditary genes, and you're not of African American descent or African descent, you can start screening beginning age 50 with PSA. How often should you be doing PSA? Earlier, the recommendation was if you've had a normal PSA, it depends on what your PSA level was. If you have a normal PSA, you could even do it every 4 to 5 years. But now, of course, everything has changed and people are getting tested every year. However, if you have a high risk, you should probably start screening with PSA beginning age 45. If you have even highest risk, meaning you have your father or brother with prostate cancer, you should start PSA test since age 40. Like I said earlier, the level of PSA is different at different age group. If you're younger and get tested with PSA, it may be 2.5. But if you're older, say you're above 70s, your PSA may be even up to 6 or 6.5. That is still considered normal. So the PSA range is based on your age. Now, sometimes you do PSA test and it goes up. Does that mean that it is cancer? No, not necessarily. There are some other things that makes your PSA go up. I know people ask, oh, I did a bike ride. That may be the reason why my PSA went up. Not necessarily. I mean, yes, of course, if you've done such intense work or activity, it's a possibility. But if you've had any infection, inflammation, urinary tract infection, these are some of the things that makes PSA go up. Sometimes as age advances, you can also have enlarged prostate as a benign condition, benign prostatic hyperplasia, BPH. That can make your PSA go up. So not every PSA equals to cancer. So what is the challenge with PSA and why was there all these changes in the guidelines and giving different recommendations? Number one, yes, we are of a concern that is falsely positive and we're just subjecting that person to doing multiple tests, including biopsies. Or it may be falsely negative. Or even if it is positive, maybe that was at an early stage prostate cancer where you just keep them on active surveillance and not have to do anything, but you're doing it, now you have an over-detection of prostate cancer. So that's why screening with PSA has to be a shared decision. You have to discuss with the patient why you're doing it, what does it mean if it's high, and are you willing to consider treatment in the event it becomes necessary. But that's the best tool that we have so far. And this is one word which I see almost everybody are kind of familiar with. It's called Gleason score. When somebody gets diagnosed with prostate cancer through a biopsy, the biopsy is reported as prostate cancer, but it also comes up with what we call a Gleason score. The pictures that you see in the left, the top one is telling us about the pattern of cells that we see under the microscope. So if the cells are cancer cells, but they resemble normal looking cells, they fall into the pattern of 1 to 3. But if they're not anything like normal looking cell, you see where the number 4 is, there are too many cells, then it's kind of an intermediate. And then when there's totally disfigured cells, cancer cells, it falls in the higher pattern of Gleason, 5 and above. And then we look at the second most common pattern. So we look at the most common pattern and the second most common pattern, and that's how we come up with the score. That's why there are 2 numbers for a Gleason score. It may be 3 plus 3, or 5 plus 4, or 4 plus 4. That's how you calculate a Gleason score, and this is huge in terms of how you risk stratify and what treatment, or whether you're offering treatment to a patient or not. Typically, when someone has a Gleason score of 6, 3 plus 3, and below, it's considered benign, or not benign, sorry, slow-growing cancer. These are different stages of prostate cancer. As I said, there are 3 lobes. You can have cancer in just one lobe when we say stage 1 on both sides, or 2 different lobes, stage 2, or you can have 2 different lobes and spread to the nearby lymph nodes, that is stage 3, or if it is spread elsewhere to the bones or other organs, it is stage 4. How do we test if the cancer has spread elsewhere? We have to do what is called bone scan. Sometimes we have to do a special type of PET scan that we call PSMA PET that helps detect if the cancer has spread to other places. Occasionally, MRI may be necessary as well. So once someone gets diagnosed with prostate cancer, how do we treat them? So it depends on a lot of factors. Is the cancer, what is the age of the person? What's their comorbid conditions? How are they physically doing? Do they have a high risk, average risk, or intermediate risk? We look into all of those factors before we make recommendations. In fact, if they have a low risk, Gleason score 6 plus 6 and below, or if they have too many medical problems that they don't think that they can handle treatment for their prostate cancer, it's perfectly okay to keep them on active surveillance. You don't need to do anything. Many a times, the prostate cancer is not the reason for their mortality. It would be something else. So it's perfectly okay, and avoid unnecessary treatment in some people who have slow-growing cancer and may not want treatment. On the other hand, there are reasonable chances that this cancer can worsen, and so you want to offer treatment. And the treatment will be either in the form of surgery, where you would remove the prostate, or you can offer radiation instead of surgery. There are pros and cons to both of these treatments. But along with radiation, majority of the time, you also have to suppress the hormone, male hormones, referred to as androgen and testosterone. You have to deprive them of the hormone or block the receptor where the hormone sits at so that they don't cause the prostate cancer to grow. And if we did give them hormone, they work in adjunct with radiation and do a better job in stopping the cancer from growing further or prevent it from spreading to other parts. Of course, there are some side effects associated with these hormonal therapy. They get things like hot flashes. It might affect their blood sugar. It might affect their cholesterol level. It affects their sexual function. There's also pros and cons to surgery and radiation. It might affect their sexual function and cause urinary symptoms as well. So you have to weigh in what is reasonable option for a patient. Do we use chemotherapy for prostate cancer? Not necessarily. We don't use in early stages, but it may become necessary if the cancer is spread to other parts of the body. I think you can turn the lights back on. With that, I just wanted to open the floor to see if you guys have any questions and share some experiences or comments about any section.
Thank you, Sramila. I'm going to leave with a question. Mark, you want to go before me?
No, you go first.
So you mentioned the BRCA test, and I know that if someone wanted to, they can pay for a BRCA test, correct?
They can pay for it?
Out of their pocket, or how does that work? Because it sounds like there's some advantages to knowing where you stand if there's a mutation earlier than later. Is that, did I hear it correctly?
So yes, if you have a family, if you have several family members with cancer, such as breast cancer, prostate cancer, pancreatic cancer, ovarian cancer, you can certainly talk to your doctor about getting genetic testing. It will be covered with your insurance if you are eligible for testing. Who would be eligible? If you have a first-degree relative, meaning your mother or sister or brother with cancer, you would certainly be covered. Or if you have second-degree relatives, and many of them, you might be covered as well. Or if you have too many cancers of various kinds in the family, you might be covered. So although there are guidelines as to who should be getting tested, the guidelines are really pretty lax and covers a broad spectrum, and almost everyone can get tested based on their risk factors. So you just have to talk to your doctor about your family history and risks that's associated in order to get tested. If you don't have anyone in your family with cancer and you are just worried that you may carry a hereditary gene, you cannot just go to your doctor and say, I want to do the test. A few years ago, direct consumer testing was available, something called 23andMe. I'm sure many of you may have heard about it. You don't need to go to a doctor. You can buy the kit. It was costing you $250 or $500, and you could get the testing. Unfortunately, the company closed and has declared bankruptcy. There's a reason for that. The method of testing that they were doing was inaccurate. It did not use what we call RNA gene in order to figure out whether you have the testing. They used a single copy gene and was coming up with results that was false, inaccurate. They missed out many of those. So the company is no longer available. So be careful when you do direct-to-consumer testing. It's always better to talk to your doctor about getting the testing.
Thank you. Mark, you had a question?
Yes, thank you so much. Wonderful information. You mentioned exercise and activity.
Yes.
Do you have any opinions about
I heard you say, mentioned about exercises and physical activity.
Now, for men and women, do you have a recommendation for what kind of exercise or activity that you would recommend?
Yeah. If you are able to do 150 minutes of moderate intensity exercise in a week, and it can be 30 minutes one day or 30 minutes 5 days a week, or it can be 20 minutes every day of the week, and those 20 minutes can be split. You can do 5 minutes in the morning, 5 minutes in the afternoon, 10 minutes in the evening. Whatever form of exercise, as long as you move, that is important. When you say moderate intensity, walking is considered moderate. Climbing stairs, that is also considered moderate. Lifting weights, you don't have to go to a fancy gym and pay a lot for membership. You can also do chair exercises. Sit on a chair, lifting your legs, arms up. You can do those exercises. That counts as well. As long as you move. That's the key. Yes. Yeah.
The Mabel K Senior Center has yoga twice a week, inside, nice and warm.
That's awesome news.
And they also have a fitness class and a balance class for older people.
What is the name of the center?
It's right by Acton.
Try that.
Center for seniors.
So for those of you that didn't know about it, there's a senior center that's offering all these exercises. Please do so. There was one person.
Yeah. Agent Orange. That's with the veterans.
Yes. Yes.
Prostate cancer is, you get that. Unfortunately,
Agent Orange has been associated with a lot of cancers, at least what we attribute it to, but we don't have definitive evidence. We are seeing men and women who are exposed to Agent Orange present with cancers, and it could not just be prostate. There's many other cancers like lymphoma, lung cancer.
and if you have that Agent Orange, you get worse.
Yes, unfortunately the case. Let me ask.
I had chemotherapy treatment in 2012. And what, in your experience, what kind of heart effects is that common?
Okay, so the question was, chemotherapy, does all chemotherapy affect the heart and does it cause problems? No, the answer to that is not all chemotherapy affects your heart. There's only a couple of chemotherapy drugs and a couple of targeted therapy drugs that affect your heart. So when you discuss with your doctor, they will mention it to you that this is a drug that might potentially cause damage to your heart, in which case it needs to be monitored frequently. In terms of chemotherapy causing heart damage, there's one drug which is referred to as red devil or doxorubicin. It can cause damage to the heart even 20, 30 years after having received it. The chances of that happening is 2%, but nevertheless it can happen later in life. There are certain targeted therapies that can cause damage to the heart, but they are reversible as soon as you stop the medication. So,
and one other question, some of the things you mentioned, cognitive.
yes.
How far out? So, like, would those things happen right away, or could they happen?
It can happen immediately as you're getting your treatment. It can last for months to years. It can even last for several years after therapy as well. However, the key to it is you cannot always blame it on chemotherapy or treatment for your cancer to have caused that. Yes, you can always do that if you want to excuse yourself from any activity, but at the same time, you also have to remember that your body is going through changes. There's something called aging that happens. It doesn't stop. And that can affect your bones, your mind, everything else. So you have to rule out other things before you can blame it on.
Thank you.
I just want to say thank you very much. You were excellent, very informative. We have breast cancer, and my mother, and I was just talking to my daughter yesterday and was talking about the genetic factor, and I'm very interested in, like, she said, oh, you know, they don't really think that it plays a role, and then you're giving us the statistics. So can you just say, I wrote it down, but I don't think I got it quick enough. The test, is it Thayer-Cusick?
Oh, that's a tool, that's an online website, Thayer-Cusick, to determine what is your risk of getting breast cancer in your lifetime.
Okay.
And if you have a risk that's about 20%, if the number comes to 20 and above, that tells you that you have a higher risk of getting breast cancer. 20 and below is average risk. On the Gale model, it is 1.7%. If you have 1.7% below, then your risk is average. Anything above that, you have a high risk. So you just have to fill in those questionnaire that they ask you, and it calculates a number and tells you what's your risk. That's to calculate what your risk is. This is not for hereditary risk. This is in general, what is your risk of getting breast cancer in your lifetime?
Can you spell the first word for me?
T-Y-R-E-R.
T-Y-R-E-R. Thank you.
C-U-S-I-C-K. Yeah, you had a question, Rita.
Dr. Aithal, that was a wonderful presentation, but I just wanted to bring to everyone's attention that my name is Rita, by the way. I am the Director of Cancer Rehab for NovaCare. So a lot of the impairments Dr. Aithal mentioned can be treated by a physical therapist or an occupational therapist. And that's how I work very closely with Dr. Aithal. For instance, fatigue, lymphedema, cognitive, like you mentioned, sexual dysfunction. So don't hesitate if you're struggling with any of these impairments. You know, if your oncologist is not as great as Dr. Aithal to refer you, you can ask for cancer rehab. But make sure when you call, it doesn't have to be through NovaCare, but make sure when you call, you need to ask whether this therapist has experience in cancer rehab, because the treatment is very different coming from an orthopedic sports rehab specialist or physical therapist versus someone who knows what they're doing. And it is covered by insurance for the most part.
Thank you. I thought one more person had their hand up. Maybe not. Yeah. I really want to thank Sharon in sharing her story. She was tremendous in what she went through, requiring chemotherapy, targeted therapy, surgery, radiation, and then endocrine therapy, estrogen blocking drug. And today, as she said, she is cancer-free and able to enjoy her quality of life.
Thank you. Just want to bring your attention to there are two ladies over here. The woman to my right is Nicole, And to her right is Sarah. And they're both, they're gonna share a few words about their survivorship. So if you just go ahead and Nicole, I appreciate you. Do you need a folder?
Yeah.
Thank you.
Good evening, everyone. Thank you, Roddy, for having me talk tonight. My name is Nicole. I want to share my breast cancer journey. Both my mom and I had breast cancer. I know talking about breast is often a taboo subject, but one that needs to be addressed. To start, I want to stress something that was vital to me. You have to like your doctors. If you don't like your doctors, you're not going to listen to anything they say, right? But you will know it when you find the right fit. Who knew that my longest long-term relationship would be with my doctors? My mom had stage 4 breast cancer when she was 42 in 1990. She had a mastectomy. Many people died from breast cancer at that time. Things are done a lot differently now. You don't leave the hospital flat-chested. The trauma of that is a whole other talk. I was diagnosed at 38, and 39 I had surgery and chemo. Chemo started a week before my birthday. Not the best gift to get. Through genetic testing, I found that I don't have the BRCA gene, but there is a gene my doctors found out that both my mom and I have, but they haven't found it yet. It was December 2018. I went for my mammogram. I was called back in because they found something in my right breast. On December 18th, the second mammogram had the same results. I had my mom waiting in the car because she had trouble walking at the time. I told her if I have to get an ultrasound, I'll call you in. I called her and said, come in. I had the ultrasound done. Afterwards, my mom and I sat in my gynecologist's office, and they asked if I had a breast surgeon, to which I said no. Before I left the office, I had an appointment set up with Dr. Michelle Fantasio for Monday, December 21st. So we weren't messing around. I had a biopsy that same day, since she did not like the way my lump felt. Dr. Fantasio told me she would call me when she gets the results, even though she would be on vacation. Christmas that year was hard. I felt like I was in limbo, waiting for the results of the biopsy. Then came the call. Dr. Fantasio let me know it was cancer. I told her I wanted a bigger set then if I have to go through this. I was a low B, and thin as a rail, believe it or not. Bigger isn't always better though. I had to meet with a plastic surgeon, Dr. Garber. We went over what kind of implants there were and whether nipples stay or go. Dr. Fantasio said I needed to have a double mastectomy. I was scheduled for surgery January 21st, 2016. After surgery and running tests, my left breast showed that in 1 to 5 years, it would be cancerous. Dr. Fantasio found that in 4 of these 6 lymph nodes that it was cancerous from the right side that were removed. This meant I had stage 2 breast cancer. I had to wait 3 weeks for my body to heal since I have systemic lupus. I couldn't have radiation. The healing process takes longer with lupus. Instead, I would have a strong cocktail of chemo. I had 6 months of chemo. I had to get a port put in to make it easier to access my vein. If the medicine was to get on my skin, it would burn. One of the first medicines began with a T. I cannot pronounce it, so not even going to try. It was like being on an emotional roller coaster. 1 minute I'm happy, next minute I'm crying. The medicine would make me start losing my hair by Easter that year. By the time I was on other medicines, I was completely bald. It's okay to mourn your hair. Losing my hair hit me hard. I was losing everything that made me feminine. My hair didn't start growing back until the end of August when I was done chemo. I lived off of cracked macaroni and cheese. I couldn't stomach eating anything else. Chemo affects everyone differently. One of the long-term effects from chemo is neuropathy. Neuropathy in my feet. Neuropathy makes me not be able to feel my feet, but I feel them other ways. With a burning sensation, especially if they're too cold, or sometimes extreme pain. Another side effect can be lymphedema. It's commonly seen after cancer treatments with lymph node removal. My mom had stage 4 lymphedema. We called it her bubble. After chemo, I was on tamoxifen, but it caused me to have excessive bleeding. After many DNCs, I needed to get a hysterectomy. Now I'm on anastrozole. Tamoxifen and anastrozole are medicines to help prevent cancer from coming back. Tamoxifen is for premenopause, and anastrozole is for postmenopause. Unfortunately, like anything, there are pros and cons to all medicine. Tamoxifen can increase the risk of uterine cancer, and you can be prone to blood clots. Anastrozole can cause loss of bone density. I would do anything to not have cancer or go through chemo again, so I take the medicine. The light at the end of the tunnel. I'm exactly 10 years to the day of my surgery. The neuropathy drives me crazy some days, but it beats the alternative. I may not have the size 6 body I used to have, but I am still here and thriving. Nothing can stop me from achieving what I set my mind to. I plan to make every day count and live life to the fullest. If it wasn't for me getting a mammogram and the support I received from other cancer survivors, especially my mom, my story would have had a very different ending. Don't forget to get your mammograms.
Sarah? Sarah's story is a little different.
Yes, it's a little different.
Why?
All of our stories are unique, but mine's a little different. So, similar where my mother was diagnosed with breast cancer when she was 46, I was 6, I'm the youngest of 5, this was 1982, and they didn't do mammograms, they didn't discuss it, they weren't talking about self-checking, and she was, raising 5 children while my father was working, and I think she ignored the symptoms, she felt lumped, ignored the symptoms to the point where it was too late, so she passed away in, like I said, 1982, December 22nd. So, breast cancer has really overshadowed my life. It has driven most of my decisions in terms of my health. I exercise, eat right, and I started that from the time I was young, and all in an effort for breast cancer not to get me. That was the thought process. So screening started very early. I started mammograms at the age of 30, MRIs, biopsies, on and on and on, because they were hypervigilant. So if they would see something, they would always send me back. And that caused an element of stress as well, where I appreciated them being so cautious, but it created a lot of stress. 10 years ago, my older sister, who became like a mother because I was 6 years old when mine passed, she was diagnosed with breast cancer. So that kind of like rocked my world. at the risk of losing her. So, I witnessed what she went through, the same with my mother. Chemotherapy, radiation, hair loss, all of it. And so I started to really think about what I should do, because I was pretty certain that I was going to get it. So 3 years ago, I started doing my research and having a conversation with my breast specialist, and she said, you have 3 options. You continue to do the mammograms, and we alternate MRIs every 6 months, so we do that, or you take tamoxifen. As I said, I live a very holistic lifestyle, so that was out of the question. I did not want to take medication. The third is the mastectomy. So I made I don't think it's extreme, but I think it's perceived as extreme to have a prophylactic mastectomy. I went flat, and that is something I had to research. Plastic surgeons are not presenting that as the first option, but I didn't want anything, again, personal decision, but I didn't want anything foreign in my body. My children were raised, they were breastfed for a year, they did their job. So I just wanted to really eliminate all risk. So, I had a plastic surgeon who did what's called an aesthetic closure. So if anybody's thinking of it, that's something you would research. And so that when they, complete the surgery, you look nice. So I did that, and again, a lot of folks questioned my decision, but 2 weeks later, the results came back. I had breast cancer. So what's amazing is that I had, a mammogram 2 weeks before my surgery. It didn't show. I had an MRI 6 months before my surgery. It didn't show. This was really very early stages, and it really was on the path that my sister was on. She was 50 by the time it was caught. I was 46 when I did the surgery. So probably in a few years, the screening would have caught it. I would have had to do radiation. I would have had to do chemotherapy, but because of the stage, I didn't have to. And that was my goal. So oftentimes when I was talking to Rodney, I wanted to go into it. He was like, nope, I want to hear it tonight. But sometimes I say, am I a survivor? But I am a survivor because I lived 40 years with the shadow of breast cancer hanging over me. I mean, I know, you think that time heals, but losing my mother was like yesterday. It doesn't go away. It never goes away. I want her here. I want her right now, even though she'd be 90. I still want her here. So it never gets easier. And so I do consider myself a survivor. Yes, I didn't have to go through the medications and everything, but I did take that shadow away, and I feel, so much better, and I don't have to do mammograms, and I just have to get checked every year. So that is my story. So that's just a different approach to it, just from, a history, a life of witnessing it and losing from it. So.
I know you want to have some comments.
I just have a comment to make. First off, do you know how much it takes to stand in front of an audience to share what you have gone through personally? The emotions that it has triggered, it brings back flashbacks of what you have been through. So I commend both of you, plus Sharon, to have shared your wonderful story. That's really amazing and commendable. Thank you for that. It's also important to note that everyone's story is different. Not all cancers behave the same. And it is important to collect all the information. The more you're empowered with knowledge, you can make better decisions for yourself with regards to your health. And it may not be the same as person B or C that has made the decision. That's really important. It's also not necessary to live your life in fear. The purpose of having these conversations today was not to create or instill fear, but really empower with that knowledge so you're equipped to make the right choice and decision for yourself. Thank you, all of you, for sharing your story. Thank you for Veterans Affairs for giving us a platform to be able to bring this discussion amidst all of you on a cold night when you could have stayed on your couch, staying warm, but you chose to be here. Thank you for that. And once again, thank you for your service that you do to our country, to one another, to our community. Sincerely, thank you.
Thank you. I know we're running a little bit behind, but a special thank you to our survivors. I think that encourages and inspires a lot of us every time. And to Dr. Aithal for your expertise, your generous, and Jack and Barbara's generous sponsorship. Real quick, I'm also a cancer survivor. And in 5 months, I will be 10 years cancer-free. And, no. My story is something that a lot of people should know about because I had a case of hemoptysis. Now what hemoptysis is where you're just bleeding a lot through your mouth. And I was bleeding almost like, I was afraid of going to the shower because I would just, so much blood would come up. And a week before I was at the dentist, and I thought it was something the dentist did that caused my bleeding. So I let the bleeding go for 2 weeks. As soon as I went, but trust me, my story is minimal compared to everybody else's story here. So I'm just sharing this because there's a couple of important little things in here that's going to make a difference in how you understand what's going on. So I visited my primary, and when I was with my primary, someone who had been here for 20 years, and as soon as he heard about the hemoptysis, he calls his ENT friend while I'm in the office. And he, and actually 2 days later, I'm at this guy's office, and they're sticking all kinds of stuff down my throat and my nose. This isn't fun. Trust me, it isn't fun. I'd rather go home and watch my Netflix show than follow it right now. But what he did is he did a biopsy within 4 or 5 days. And the biopsy proved that there was cancer there. And next thing you know, I'm at Jefferson, and I'm going through my first PET scan and MRI and all that cool stuff. And it was proven, well, the biopsy proved that there was a cancer. But he used a Da Vinci machine at Jefferson, and it's like a robot that goes down and puts a bunch of long fingers in there, does a bunch of cool stuff, and they removed it. And and then after that, they do the lymph nodes, and they took 21 lymph nodes out of my throat. And then there's some therapy after. But basically, it took me about 4 months to recover. But there's a lot of speed to how you respond, and the good news, if I didn't have the hemoptysis, my story could be much different. Anyway, stuff happens. Where's Sam? Sam and I have something for you. Okay? This is it, right? So this is Dr. Romanelli. And Dr. Romanelli has, she was in the Army for 29 years, worked for Army Intelligence, and I'd love to embarrass her when I do this. This is good stuff.
Do it.
Do it. So she worked for Army Intelligence, and she also worked for the Pentagon. This lady is the one credited for identifying Osama bin Laden. Wow. And she was very involved with integrating the information about all these different military services because they're always onto something, and it's really about what's going on. So, but unless you know how all that data comes together, you really don't know that this guy was really he was a headache about to happen. Okay, all right. So, will you come up here, please? Okay?
This is not what I'm for.
Good. Yeah, but this is good stuff.
Well, we have a couple of things.
Where's the mic?
The mic. This is my job. I can do that.
All right, you hold on.
I can be the center.
All right. We have a letter to you on behalf of the American Legion. We want to thank you for your presentation, your wonderful presentation. I'll let you take a look at that later. I don't want to go and read it.
Yep.
But we also have a certificate of appreciation. In recognition and sincere appreciation of outstanding service and assistance which contributed to the advancement of the American Legion programs and the activities dedicated to God and country. For Dr. Sramila, Aithal. And of course, this is a challenge coin. I don't know if you know the story about challenge coins. Military people do. Do you want to tell it? Okay.
You're doing a fine job.
My first introduction to a challenge coin was when I was living in Germany. This is way, way back, when I first was in the service. And one of the guys, usually mostly guys, not too many of us women in the service, threw one down in the bar and challenged everybody else to bring their coins, and I was like, you know, naive, so I did not know what a challenge coin was. The whole idea is if you don't have a challenge coin afterwards, you have to pay for everybody's drink. Let it be said, that was the first time and the only time I did not have a challenge coin. So here's a challenge coin so that if somebody challenges you, you'll know what to do.
Thank you. I'm really humbled to have received it, but I want to dedicate all this to the patients that I serve who has made me who I am. I really want to thank all of the patients, and this is for that.
This is another little thing that we want to give to you. And since I am a Mary Kay lady, this is a little bit of Mary Kay. And for your wonderful hands, this is our satin hands. I had to bring that in.
Thank you. Thank you, Sam. So we're going to wrap up a bit. Thanks for making this evening as a resounding success. We would hope that more people would have heard the stories today. But let's carry this energy forward. Continue to be a beacon of hope. Thank you from the bottom of our hearts. I just need to make a couple of comments. So we have a young lady named Rita. Rita sits over there. I will invite you to come up and grab one of these pamphlets and one of these cards, because it gets into a lot of information about rehab, post-cancer or during your cancer survivorship. I was made aware of an organization called Mary's Place by the Sea. And it's a retreat, a cancer retreat center. And apparently if you're a cancer survivor, you're going through whatever it is you're going through, and you need a place, a safe place to be, this is open for all women, free of charge. Okay? And so that's that. And then we have three ladies here. I think I got Lorraine Ward, I think you've got Judy, and I won't forget Mary Kay. Okay? Can you just raise your hands here? They're related and connected to the next event, which will be done on Wednesday, March 11th, about human trafficking. Now, I'm gonna make a statement here that's quite stunning, okay? First of all, I'm not speaking for you guys, but I'm speaking for what I've learned. Every 30 seconds, there's a human trafficking incident. And there is a unit in New Jersey that is focused on human trafficking. I think it's about 7 police, okay? When they speak on March 11th, one of those policemen from the human trafficking unit will be here. Now, there's a movie, so this kind of close your eyes or whatever, but I'm gonna just share a quick statement. There's a movie called The Sound of Freedom. It's on Amazon. And there's this bad guy who's a human trafficker, and there's another bad guy who's a drug dealer. And the human trafficker tells that drug dealer, You know, when you sell your drugs, you make one sale. But you see this little girl here? I can sell her 10 times a day for 10 years. Okay? I want you to come back here because I was talking to one of the politicians in Hanfield, won't tell you who it is. They didn't think it was really relevant about human trafficking in this area. Trust me, you don't know half of what you should not know. You all right? March 11th. All right, so we got that. I don't think I missed anything. We have a blood drive coming up on Saturday, February 21st. And then finally, you can, up here, are these roses for every woman in this building. So while you're picking up your roses, it's a good opportunity to make a donation, and it's a good opportunity to get one of these. Thank you, thank you, thank you. Appreciate you. Yes, ma'am.
George, can I just say one thing? When we come back, we'll also have our state trooper, so we have a survivor.
Yes.
We have a survivor that will be here with us that night sharing her story. And you will not want to miss that.
Thank you. Good night, everyone.
Good night.